I'm going to be taking you through the nutritional considerations in pediatric surgical oncology patients in KNH. I'll start with saying there's a running joke among my colleagues. That I was assigned this topic because I'm categorized as underweight. So when in me there present, do not have any disclosures to make as I start these presentations. So my nutrition can be defined as either overweight or underweight, as we all know. And pediatric patients with tumors and those with chronic illnesses, especially those who require long-term follow-up and nutritional interventions, are vulnerable to nutrition-related complications. And those who require surgical interventions especially are subject to both physiological and emotional stress. And they require a period when the nutritional needs may need to be temporarily adjusted. They are predisposed to infections, impaired wound healing, and a reduced quality of life, and therefore proper planning is needed to address their nutritional concerns. So this is a nutrition care process. This is borrowed from the Nutritional Journal of 2022, and this flowchart stroke circle basically is a summary of what my entire presentation is made up. The first two circles especially is how we identify the nutritional problem in the study of identification of the nutritional consideration. Then point 3 and 4 is how we solve. So we start with nutritional assessment and reassessment of the patients. Then we come up with an issue or diagnosis. Then we plan and intervene, and then we monitor and evaluate and follow these patients up. So the broad objective of this was to review the nutritional consideration in pediatric surgical oncology patients at KNH. The specific objectives were to describe the preoperative nutritional assessment and reassessment in pediatric surgical oncology patients. The second one was to determine the common pre-op and post-op nutritional concerns. And the third one was to determine the strategies for pre-op, intra-op, and post-op nutritional intervention. So this is the data collection sheet that I used to collect the data, and it's the nutrition care process form that KNH uses. It's composed of the biodata, which has the age, the diagnosis, the sex. Then we have the assessment data, the biochemical data, physical findings, the nutritional diagnosis, the problem and intervention. So I'm going to go to the results of the cross-sectional survey. What I did, I sampled 46 patients who were in 3 wards. All the files of the patients who were in the wards were used. There was really no exclusion criteria. The age of these patients, the youngest patient was 9 months old, with the oldest patient being 14 years of age. And majority of the patients ranged from 3 to 8 years of age. That was 61% of the patient, with the median age being 5 years of age. The male to female ratio was 1:1. And the most commonly seen tumor was the nephroblastoma at 52%, rhabdomyosarcoma followed at 9%, and 4% was Ewing sarcoma, 7% being the gliomas, and the 4% was osteochondromas. The rest was at 2.2%, that is 1 patient each. So for the nutritional assessment, this is how we assess the patient on whether we filled that part or not. So for the patient and client history, 69% of the templates, that is the total number being 32 to 46, were filled. For the food and nutritional related history, only 57% of the form was filled. For the clinical examination, only 52% of that chart was filled. And for biochemical data tests and procedures, 80% were filled. Of note is that there was no field nutritional diagnosis and intervention for all the 46 patients who were sampled. So this was how we did the anthropometric assessment of the patients. So this is a delineation. So the 73% means that 73% out of the 100 patients were sampled had field weights. 65% had their heights taken, 58% had their marks taken, BMI 43% of them. There was no patient who had a Z score, and 17% had their heights for age. So we are going to go to the discussion. A nutritional assessment basically is the process of obtaining, verifying, and interpreting data so that we are able to identify the nutrition-related issues, their causes, and significance. And the information that you want to obtain is the food and nutrition-related history, the anthropometric measurements, the biochemical data, tests and procedures, a focused physical examination, and a client and a patient history. So traditionally, the measures which we use to take anthropometric measurements is a weight for height, a height for age, both weight and height, BMI, the ideal body weight, biceps skin fold thickness. And what is that anthropometry has been shown to be a more sensitive tool for patients with abdominal masses because they tend to present with normal weight despite having severe malnutrition. And there are several studies which have shown that a significantly higher patients will be classified as acutely malnourished when you use WMAC as a measure of assessment compared to weight for height or a BMI, unlike the assessment that we are using. So the biochemical indicators of malnutrition, we use albumin, prealbumin, the retinol binding protein, transferrin, BUN, and creatinine height index. ISPEN guidelines, however, recommend that serum albumin and prealbumin did not serve as valid proxy measures of total body protein because they tend to be influenced by acute stress markers and illnesses and therefore should not be used as nutritional markers. So the nutritional concerns as found in literature and what we found in the survey was that oral ulcers, change in food taste, abdominal pain and poor appetite, nausea and vomiting, diarrhea and constipation, and also feeding difficulties due to facial masses. So the nutritional intervention is broadly classified into three. You either have a feeding regimen, counseling, and supplementation with dietary modifications. Whether you use oral, enteral, or parenteral feeds depend on whether the patient is able to take it in orally or if they are vomiting too much and they are unable to sustain their feeds. If you anticipate that they are going to be NPO for more than 2 days for the neonates or more than 5 days for the older kids, we were doing both high protein and caloric diets, and for the supplementations we were using the ready-to-use therapeutic feeds and ready-to-use supplemental feeds and supplementary diet with we will supplement the feeds. So for my conclusions and recommendations, what we note is that nutritional screening for hospitalized patients is variable in different settings, and in KNH it's done variably in the different wards, and that we have different methods that are used to assess the nutritional status, and that is both the anthropometric measurements, the criteria and cutoff points. So to make an accurate estimation of the prevalence of cancer-related malnutrition is quite difficult. We need to have a disease-specific nutrition score instead of the blanket scoring system that we use, which will take into account the disease and the intensity of the treatment. And it's also necessary to integrate anthropometric parameters, the lab data, the body composition test, the caloric intake assessment, and energy expenditure so as to better define the nutritional status of children with cancer. So this brings me to an end.
Conclude the chapter.